Hey, everyone joining. We'll get started in just a moment as people settle in. This is the Silver Hill Grand Rounds series with Dr. Gary Small. Thanks so much for joining, and I'll just wait about 20 seconds before we get started as people settle in. All right. Welcome, everybody. I am Dr. Jeff Katzman, the Director of Education here at Silver Hill Hospital, and we are delighted to have you join us. We are absolutely privileged to welcome Dr. Gary Small, who will be presenting on the topic of geriatric psychiatry, and the impact of the electronic age on the brain, treating people with dementing illnesses. I will have a great pleasure of introducing him in a moment, but first a little bit of housekeeping. Our next Grand Rounds will actually take place next week. We're usually every other week, but we'll be meeting next week as we're making use of the third Wednesday in March on the 29th. And we have two speakers presenting, Dr. Catherine Rosenblum and Dr. Maria Musak, who are both attachment experts and will talk to us on groups they run called From Zero to Thrive, the Science and Practice of Nurturing Early Relationships. So hope you can all join us there and bring a friend along. Back to today's lecture. As you can appreciate, your questions remain an important part of our Grand Rounds lectures. I will moderate a Q&A discussion with Dr. Small at the end of this lecture, and this is your opportunity to put forward questions and comments to Dr. Small. So you can go ahead and submit a question anytime during the presentation by using the Q&A box, either with your name, or if you prefer, you can submit it anonymously. If you wish to receive continuing education credits, please complete the evaluation survey that will pop up in the browser when the webinar concludes. We will also email a copy of the survey to today's participants. As we're getting close to the end of our first quarter this year, I wanted to make one further note regarding our evaluation surveys. When completing the survey, you will see our last question, which is a valuable opportunity for us to read your feedback for your education gaps or needs, topics of suggestion, and speaker ideas. We review and reference this question thoroughly when planning future Grand Rounds, which is an ongoing task of our education team. So thank you in advance for taking the time to complete this question, not just today, but after all our Grand Rounds programs. Finally, disclosures. No planners of this activity have indicated a relevant financial relationship with an ACCME defined commercial interest. Dr. Small will show a slide with his own disclosures. It is now my absolute pleasure and honor to introduce our guest speaker today, Dr. Gary Small. Dr. Small is the chair of psychiatry at Hackensack University Medical Center, behavioral health physician-in-chief, and the Hovnanian Family Foundation endowed chair in behavioral health for Hackensack Meridian Health. He's a co-inventor of the first positron emission tomography, or PET scanning method, that provides images in living people of the physical evidence of Alzheimer's disease. In addition to testing compounds that may benefit cognitive abilities and possibly delay the onset of Alzheimer's disease symptoms, Dr. Small has studied and developed lifestyle and memory training programs for improving cognition and healthy aging. Dr. Small has authored over 500 scientific works and received numerous awards and honors, including the American Psychiatric Association's Weinberg Award for Excellence in Geriatric Psychiatry. Scientific American magazine named him one of the world's top 50 innovators in science and technology. He's the author of 12 popular books, including the New York Times bestseller, The Memory Bible. On a personal note, I first met Dr. Small long ago when I interviewed for residency training at UCLA, where he had long been a beloved faculty member and teacher to many students like myself. I always felt quite fortunate to get to learn from such a smart and personable faculty member, and really enjoyed our conversations in the hallways of the UCLA Neuropsychiatric Institute. And I bet that many people in Los Angeles miss him there a great deal. Thank you so much, Dr. Small, for accepting our invitation to talk today at Silver Hill Grand Rounds. It is so great to see you again, to spend some time catching up, and it's a pleasure and honor to pass the baton to you.
Well, thank you, Dr. Katzman. It's an honor for me to be here speaking with all of you and actually reminiscing with you in the moments before this discussion. Let me just say that it's interesting in our conversation how time does fly by, and our perception of time is really changing as we age. And part of the discussion was how there's often many chapters in individuals' lives. And as I go through this discussion, I'll try to relate it to some of my own experience and how it rings true for me. And just as one example, as we get into how to protect the brain from aging, one thing that's very important is having purpose and meaning in one's life, and to be engaged in social activities, and particularly to challenge ourselves. And so later in my career, I think I was delirious with a fever, and a headhunter contacted me and said, well, why don't you move to the Northeast? I'd lived in the Northeast before, so I knew what it was like. And I thought, well, why not? This would be a fun adventure. And it certainly has. And one thing I've noticed is coming to a new area and learning new things and learning new job skills has sharpened my cognitive ability. There's no question about it. So there's something about it. And we'll talk about how you want to train, but you don't want to strain your brain, because if it's too daunting, it's going to be overwhelming. And on the other side of it, if you're in the rut and doing the same old thing over and over again, it gets boring and it's less engaging. And I think life is less fulfilling. So let's move forward with some of the content. And this is getting into this talk. It's really two talks for the price of one, so to speak. And there's overlap. I'm going to talk about some of our work that we've done and how new technology affects our brains and our behavior, and that is really something that has to do with the lifespan. And then, more specifically, how that might relate to geriatric psychiatry, and particularly in geriatric psychiatry, the challenges we have with the aging brain. Here are my disclosures and potential conflicts of interest. And I want to begin by focusing on this whole area of new technology and the brain. And it's quite an interesting area. It's something that I got interested in when my children were in their teens. And both my wife and I were concerned about how much time they spent with their technology. And I remember a couple of interesting experiences. My son was very much into playing video games. I remember once sitting in the den watching television and hearing him in the other room playing video games. And finally I said, Harry, get off that video game and come over here and watch television with me. And, it sounded odd coming out, because it seemed like, well, I was concerned about video overuse and how that might have a negative effect on him. But yet I was asking him to watch television with me. So as it turned out, my concerns were probably a little bit overblown, because the video game he was playing, he had earphones on and he was interacting with his friends. So it was kind of a social interaction. And also I was looking for that as well, for him to come and join me to watch television and have conversations. So it's clear that our relationship with technology, how it affects our behavior, how it affects our brain, is quite complex. But I would submit to you that it is changing our lives, and it's also changing our brains. And a concern I have, and many do, that a young person's brain is most sensitive and exposed to this. And so to understand the phenomenon, we need to think about the digital natives and the digital immigrants. So digital natives are those of our society, the young individuals who grow up with all this technology, being exposed quite a bit. And digital natives is the older group that comes to the technology later in life. And so what we have is not just a generation gap, but a bit of a brain gap, which I think when I was first formulating these ideas, this was about over a decade ago. I think it's changing because I think that the older generation is very much immersed in the technology. But the skill that what we have to do is kind of upgrade the tech skills of the older generation and help the younger generation with their face-to-face communication skills, sort of bridging that gap. So now from there, let's just think about how personal our relationship is with technology. And when I would talk about this to groups in the room, I'd actually ask people to do this experiment in person. Since this is a virtual conference, I just want you to imagine it and imagine how you would feel. So if, when we want to be respectful in a social situation, we turn off our devices. So you can and when you turn on your cell phone or your device, it usually makes you feel pretty good because you're connected. Something that can kind of stir up anxiety is to hand your phone to a stranger. What is that? Is that person going to see my personal stuff? Am I going to miss an important text? And that usually brings on panic or anxiety. Or another more common situation is you leave the house without your cell phone and you have a moment of panic. You think, oh my God, how are people going to get in touch with me? If you can't go back and get it, actually, usually people calm down because they're able to take a vacation from their online world and sort of reset their neurocircuitry. Now, a principle to keep in mind when we're thinking about how technology affects us, and we'll also talk a bit about, the new technologies that help us communicate and function more effectively in the world. But this principle is that our brains are changing from moment to moment. So there's a lot of different sensory stimulation from moment to moment that cause chemical reactions in the brain, whether you're looking at a computer screen, reading a book, or looking at someone's facial expression. It triggers a whole cascade of neurocircuitry. So light comes into your eye, it hits the retina. There are neurotransmitters and chemical reactions through the optic nerve. Messages travel along neural networks. And it gets to our brain, which, as we know, is a very specialized organ. And here we just see in this cartoon, some of the important areas of the brain for language, Broca's area, frontal lobe, for problem solving, visual cortex in the back, and so forth. It's just really, it's an organ that's fascinated me. On average, it weighs about 3 pounds, but there are just billions and billions and trillions of synapses or connective sites throughout the brain. So it's quite complex. And there's been so many studies over the years looking at this. And these are just PET scan studies showing how differently the brain reacts depending on the mental task. So whether you're hearing something, seeing something, speaking or generating words, different areas of the brain get involved. So, your perceptions can stir an emotional reaction, can jog a repressed memory. Maybe that actually happened in the conversation with Dr. Katzman, thinking about how we first met at UCLA decades ago. And it's always fun and interesting to go back to those memories. And there are also automatic or autonomic responses that are triggered in our brain. And this photomicrograph of neurocircuitry, it looks like a bunch of spaghetti thrown up against a wall, but it's you all know, if you're a neuroscientist or in the mental health field, that it's much more than spaghetti. There's a lot going on. And one of the important things that's going on is this plasticity in our neurocircuitry, how changeable it is. And we can use the computer again as an analogy. We have our brains from birth, and they're like computers. You have basic programs that are built in, and there's a lot of room on your hard drive for a lot of programming. And you have these specialized circuits that are built in, the so-called macros or shortcuts in your computer. And that's kind of how our brain is. And the other principle that's very important with this neurocircuitry is the more you experience different mental states or mental experiences, the neurocircuits that control those experiences will strengthen. But that is at a cost. That means you're not going to be spending time with other neurocircuitry and other mental experiences, and those will weaken. And that kind of gets us into this brain gap where the overuse of technology strengthens the neurocircuitry, allowing us to manipulate the devices, but it may weaken some of our human contact skills. And then we bring up this issue of the malleable young brain. And we know when we're young, we can learn languages and musical instruments very quickly. But there's a downside to the young brain. We're always hearing about the aging brain and how challenging that is. And there are challenges, although there are some upsides to an older brain. But young people, their frontal lobes and their emotional experiences, particularly their empathy abilities, are not quite taken hold at young ages. And in fact, from birth throughout adolescence, there's a process known as pruning, where 60% of synapses are literally pruned away during that period. And then there's the concept of brain evolution over so many thousands and thousands of years that we've been looking at. And there have been breakthroughs and milestones in brain evolution when our ancestors, for example, discovered the handheld tool. That was a real acceleration in brain evolution with that discovery. The frontal lobe enlarged, so the thinking brain became enlarged during that period of discovering a handheld tool. And also it really led to grammatical language and social networking. So as a society, we really advanced considerably with that single discovery. So there was an acceleration in brain evolution. And what I would ask you, what is going to happen to our brains as a result of this new handheld tool, which is probably disappearing quickly into other more advanced tools. But what I would say, it's going to probably change things. And it gets us into the ideas that Charles Darwin put forward with natural selection, that genetic variants that adapt best to the environment are most likely to survive. And we see that with the tremendous variety in our species. As our environment changes from a more primitive environment to maybe a more technological environment, the question is, how will this affect brain evolution? And I would submit to you, it's going to kind of change things. And this may be the future human. And that gets us into the discussion about digital natives, who are the younger generation that are born into the technology. They have access to all these devices 24/7. I remember my daughter, sleeping almost with her, then the BlackBerry was in vogue. And, it was the first thing she checked in the morning. She was just so connected to it. But I also remember having a conversation with her. She was about 15 or 16 at the time. And I said, well, Rachel, when I'm talking to you and you're texting at the same time, I just don't feel that you're connecting with me. And her response was to look up from her device and look in my eyes and say, well, don't worry, Dad, I don't do this with my teachers. And then went right back to her texting. So, the point is that the technology train is out of the station. We can't stop it. We can try to manage it as best as we can, but we have to be aware of how this continual use of technology is affecting people. And it's not just young people, but I think people of all ages now, that older generations are really connected with their devices in the same way. And it has to do with empathy skills and complex reasoning skills. And you see a lot of it in the popular literature: slow down, brave multitaskers, and don't read this in traffic. Devastating that can be when people text while they're driving. Even a while back in London, they put protective padding around trees and lampposts in the city, so people wouldn't injure themselves while they're texting and walking, bumping into things. And with all this use of the technology, it's generating a lot of data, and there's just so much in the literature now. Even years ago, there were analyses like this one, social networks like Facebook, how they spread mood states. And this was an analysis of emotional content of billions of Facebook updates. And they found on rainy days, negative Facebook posts increase, positive posts decrease. That's pretty obvious. But for every sad post generated, there's 1.3 negative posts among friends, and every happy post generates 1.8 positive posts among friends. And one of the aspects of healthy aging and successful aging is remaining socially connected and having a positive attitude. And that can spread from individual to individual. We also hear about the concerns about technology and addiction. And this is something controversial. The American Psychiatric Association doesn't recognize technology addiction, but there's some discussion about it and compulsive behaviors. But I would pose to you that it's very similar to any kind of addiction, that dopamine circuitry gets involved, the anterior cingulate pathways are involved, and it can take any form from shopping online to gambling to virtual games. I remember seeing a documentary years ago where these people were playing these virtual games where they had avatars that were better versions of themselves, but they were spending 12, 14 hours a day in these sites. So neglecting their personal lives. And why do people get hooked on technology? Well, there's a couple things going on. We can take email as an example of looking at it in terms of operant conditioning. So most of the emails we go to, I just feel like I'm a human filter. You're just looking at boring ads or just different things that are not relevant, and one after another. It's pretty bad until you get one of these. The letter you submitted to the American Journal of Psychiatry, they're interested. And isn't that nice? And you can follow up on something positive. So as a result of that one positive email, you end up checking your email over and over again. Now, if instead every email was a happy face, it wouldn't be as compelling. It wouldn't be as addictive an experience. Now, here's another study that I think supports my argument that these spending so much time online with the technology as it is today. Now, in the future, it may become much more sophisticated, much maybe like in Star Wars, where you have avatars that look three-dimensional that beam into your room. But now it's still relatively primitive. And so they did a study where they had almost 200 students who were playing video games. And then they tested their emotional intelligence. And the way they looked at emotional intelligence was to look at, have the subjects look at a neutral face, and then they would very quickly morph into either an angry face or a happy face. And so they timed how quickly the research participants could recognize the happy face. And they found that after playing a video game, their emotional intelligence went down. But we can talk about some of the positives of using the technology in just a moment. But here's another study pointing out that this kind of interference with face-to-face human contact skills is not permanent. In this study, we looked at 6th graders who went away to nature camp for 5 days. So they had no screen time for 5 days. And we again tested their emotional intelligence by the facial recognition emotional task. And then also we tested their social intelligence. We had them look at videos and had them explain to us what's the social context of the video. We had a control group that continued using their devices and watching TV about 4 hours a day. So the control group, there were no changes in emotional or social intelligence, but in the group that went away to nature camp, there were significant improvements in both. So it's not permanent brain damage. Other issues involve attention deficit, too much screen time causing that. They found in kids that lowers their GPA if they're spending too much time with screens, also worsens attention skills. And then these kinds of problems are now leaking into the older generation, which has been reluctant to get involved with technology or not early adapters. But that has changed quite rapidly. We see so many of us really very involved with technology. I remember my father was a radiologist, and his idea of technology was working a remote control. But when his health system segued into electronic medical records, within a week, he was he was really very skilled in using the technology. So when we need to use it, when there's a purpose, we get into it. And I think a lot of older adults started getting into it because they like sharing photos, they like communicating with their loved ones. And certainly with the pandemic, that's really catapulted technology into the forefront, not just with the older generation, but also with healthcare as well. But there's still this reluctance to get involved, and this is the kind of old school devices that this generation liked. So, and there are a lot of questions. Is technology weakening your memory ability because you're distracted so much? And I'd have people come into my office many times saying, "Well, Dr. Small, I'm worried I can't remember phone numbers anymore." And this kind of speaks to how the brain tends to be a utility organ. I mean, there's no reason to memorize phone numbers anymore because you have shortcuts to it. You're much better off learning to memorize names and faces because that has a social implication. And actually, I advise people, don't worry about your memory because we know that your memory will be worse if you worry about it. And then, there's popular culture is Google making us stupid. And I'll just point out if there's any digital natives at this conference, that stupid is intentionally misspelled. And so we got into that in a study we called Your Brain on Google. I was curious to see what the brain looked like the first time people searched online. And to do this study, we had to recruit people who had never searched online. And that was probably the hardest part of the study, but we were able to find a dozen internet naive individuals who were in the older age group, and we compared them to some internet savvy individuals. You see they were very similar in terms of their education and so forth. It just differed in terms of their computer use. And we put them in a functional MRI scanner. We had them wear special goggles, and we in the experiment, we had them look at simulated internet search pages, and they operated a mouse at their side. And it was quite interesting. So this is what the brain looked like in the red area. This is a composite of the subjects. This is what it looked like for the internet naive subjects when they searched online for the first time. But look at what the internet savvy, what their brains look like. Their brains were having a party. There was at least twofold increased activity throughout the brain. And we repeated the study later where we took those internet naive people, we had them search online for an hour each day for a week. And there were significant increases in brain activity when we repeated the experiment. So you can teach an old brain new tricks. And we think, how I understand what's going on, when you are exposed to a new mental task, let's say you get a new car and you've got to set the clock in the car. You don't understand the technology. It takes you a while. And so there's not much neural engagement. But once you figure it out, there's an uptick in that engagement. I think that's what we're seeing when people search online, because our brains crave novelty. We're always looking for new stuff. And so we're constantly searching online and looking at this new stuff. But we also teach people memory techniques. And when we do experiments there, when we have them try to remember things, we find there's a decrease in neural activity. So their brains become efficient. And so, the question is it good or bad if your neural circuits are activated? It depends on what the purpose is. If you're trying to exercise your mind, then yes, it would be good. You want to play games that are engaging and fun. If you want to be better at remembering people's names and faces, you don't want it to be an exercise. You want it to be an easy mental task. And so, these video games, it's not just distracting us from our jobs in the real world and hurting our memory, but you can improve some mental skills from video games. You can improve multitasking skills from certain games. You can even boost intelligence by improving working memory using some of these games, like the old game of concentration, where there are games out there. If you go search in the App Store IQ Boost, you'll find one of these games that actually improves very short-term memory, which helps us solve problems. And the studies show that when you play these games, it actually improves your fluid intelligence or your ability to solve problems. And surgeons who play video games make fewer errors in the operating room. So it boosts hand-eye coordination and some of your peripheral vision. And several of us just finished a review chapter that's going to be coming out I think in the Encyclopedia of Human Behavior on both the risks of our digital technology as well as some of the upsides of it and how it's really transformed healthcare, telehealth, and so forth. And maybe we can get into this a bit more during the Q&A session of this conversation. Now, and before we get into that, let's now segue into old age psychiatry. And the issue that we're all concerned about is dementia as our brains age and Alzheimer's disease. Now, we didn't know about Alzheimer's disease until 1906 when Professor Alois Alzheimer presented the first case to the medical community. It was a 51-year-old woman who got confused and had a rapid progression of the confusion, actually also with some psychosis. After 4 years, she died. And what was novel was that Professor Alzheimer, who also, by the way, was a psychiatrist, he identified these amyloid plaques and tau tangles in the autopsy tissue of this patient. So this was the first time it was presented to the medical community, but there wasn't too much excitement because it was assumed that this was just a rare pre-senile dementia because the woman was in her 50s. In 1968, a group of pathologists, neuropathologists, published a case series of people with what we used to call senility or cognitive impairment in old age, and they saw the same plaques and tangles. Now, this led to a lot of concern that now we have an epidemic of late onset Alzheimer's disease. But I mean, the silver lining was it forced doctors and scientists to look for better ways to diagnose these problems and to treat them. You can see how age is a critical risk factor for dementia, which can be defined as a cognitive impairment that interferes with a person's independence. And in fact, it's the greatest single risk factor for dementia. So thanks to medical technology, we're all living longer. The rub is our brains weren't really engineered to live that long. So we have a high rate of dementia, and Alzheimer's disease is the most common cause of late life dementia. What we see in an Alzheimer brain is atrophy compared to a normal brain. And if you look at the insets, as I said, under the microscope, you see these amyloid plaques and tau tangles, but notice the insets in the normal brain, in the frontal lobe and the temporal lobe, there's an occasional plaque and tangle. So what we've learned from multiple studies is that these abnormal protein deposits accumulate over a lifetime. And we can follow that accumulation by looking at brain PET scans. We can follow it with neuropsychological testing. And we tend to think about 3 stages of brain aging. So if we plot brain health on the vertical axis versus age, there's first normal aging, which is all the forgetfulness that we joke about. Can't find your keys, can't remember somebody's name, it comes back to you, the tip of the tongue phenomenon. And that generally is stable. It is not too much of a threat. But if it does progress, then people develop what's called mild cognitive impairment, which is a risk state for developing dementia. If you have mild cognitive impairment and a memory issue, that means you have a 10% risk of converting to dementia each year. So after 5 years, those people with amnestic MCI will go on to get dementia. And what determines whether they get it or not? It's a combination of factors. Certainly there are genetic risks. Rarely there's a genetic mutation, an error in the DNA in chromosome 19 or chromosome 21. And in those situations, and this affects less than 1% of cases, there's an autosomal dominant inheritance pattern in the family. So 50% of relatives get the illness at an early age. If you see a family like that, you can refer them to a genetic counselor and they can decide whether they want to find out if they're going to get Alzheimer's disease. Not everybody goes for that, but they can have that option. More commonly, there are genetic risks. So these are common alleles that are in the DNA, and they don't cause the disease. But if you have the risk allele, it increases the likelihood you'll get the disease at a younger age. So the one we know the most about is apolipoprotein E4. About 1 out of 5 of us are ApoE carriers, E4 carriers, but we use it more in our research than in clinical practice. People can still get their ApoE results. They'll get it if they do 23andMe, and that can be anxiety provoking for people. There've been some studies showing if you inform ApoE4 carriers that they are carriers, they actually perform worse on memory tests. So we don't generally recommend it in clinical settings. When we look at people who have the genetic risk, and this is a study done on people who just had normal aging or maybe MCI, we found that on their neuropsychological testing, you couldn't differentiate them. But if you looked at their brain stress tests, so if we put them in the MRI scanner and had them memorize words, the people with the genetic risks indicated by the brains on top, their brains were working harder than those without the genetic risk. And when we followed these people after 2 years, the harder your brain worked at baseline, the worse your memory was 2 years later. So we think what happens is people naturally compensate for these kinds of genetic problems, but at some point that compensatory response breaks down, and that's when dementia breaks in. Now, Dr. Katzman mentioned the amyloid tau PET scan we invented at UCLA, and this is just an animation showing you 20 scans, three-dimensional projections on the 3D brain, and it's a correlation of memory score to the degree of amyloid and tau in the brain in these people, and it spans from people with just normal aging all the way to dementia. And you notice that as the animation loops around and we start, let's say, with the first cases in just a moment, there's very little amyloid. Here you can see it in the temporal lobe, and then it builds up. And this mirrors exactly what you see on autopsy studies. So we can detect these problems decades before people actually have dementia. Now, if you look at memory versus time, if we do nothing to protect our brains, depending on your genetic predisposition and other factors, you're going to get worse. Our goal is to identify problems early on and intervene early so we can slow down decline. Unfortunately, there's a lot of denial, a lot of pushback, and a lot of difficulty in health systems to really detect the problems early and intervene early. So we tend to do too little too late and have less of an impact. So what do you do if you see someone who has concern about their cognition? Well, you know, this slide is one I've been showing for decades because it hasn't changed all that much. You want to get a good history from people who know the patient well, because they may not remember well all the details. You want to get an idea of the rate of onset of the illness. If there are co-occurring illnesses that might increase risk, like diabetes or neurologic illness. You want to do a mental status exam with some standardized scales. Always look for depression, because that can create situations that look like dementia, particularly in late life. Do some kind of functional assessment. You know, the functional assessment for me starts when I see people walking down the hall. I used to see them walk down the hall of my office, and you know, just by their gait, we know that as people get MCI, they get some gait instability often, or whether they're coming in alone, that tells me that maybe they're still independent, or whether there's a family member with them. But then you want to ask more specifically, you want to do laboratory testing to rule out medical causes of dementia. And then brain imaging, what's recommended is generally a structural scan to see if there's a space occupying lesion. A lot of times you just see atrophy, which can be a normal part of aging. An FDG PET scan where you're looking at glucose metabolism. Medicare will pay for that if you are concerned about differentiating Alzheimer's disease, which will show you more posterior hypometabolism, so less warm colors in the back of the brain versus frontal temporal dementia, where you'll see the temporal and frontal lobe affected. And then there are the newer amyloid plaque and tau tangle scans that are used, that would probably be used if you're going to do an anti-amyloid treatment. Just a list of some of the conditions that can lead to cognitive problems that you want to rule out. And also to make the point, when we're talking about memory, it's not all about genetics. It's also about behavior. In fact, for the average person, genetics has less of an impact than non-genetic factors. We did a study with Gallup where they interviewed over 18,000 people across the US, and we categorized the respondents into young, middle-aged, and old. And we found, not surprisingly, this is the first time Gallup had asked people about memory. We did find that healthy behaviors were more common in older adults, but the more healthy behaviors people were engaged in, the fewer memory complaints they experienced, which was consistent with our prediction. Why would healthy behaviors be more common in older adults? Probably because if you're reckless and you're unhealthy early in life, you're not going to live to old age and have Gallup call you up for a poll. And as we get older, the doctors start telling us, well, you got to watch your blood pressure. You shouldn't be smoking. You should be eating right. And we're less under the spell of invincibility of youth. So what is it about healthy lifestyle? What are some of the behaviors that are important? And I'm just listing some of the areas that I'll touch upon today that are quite important. Physical conditioning, mental stimulation, stress management, nutrition. And these are all, if we're talking about technology, a lot of these lifestyle behaviors can be supported by technology. I know during the pandemic, a lot of people worked out. They wouldn't go to the gym, but they worked out with their trainer on video conferencing. You could maintain your social contacts through video conferencing. There are a lot of apps to help you get restful sleep. The technology has penetrated remarkably into our health systems. We just had a grand rounds presentation today and from the health system where they said, well, 90% of their outpatient visits are in telepsych. People prefer the convenience of it. But let's get a little more granular about some of the mechanisms behind these non-genetic factors and start with exercise, because I think we have the most compelling scientific evidence that if you engage in regular exercise, it's going to protect your brain. Your brain will be larger, your memory and especially your problem-solving skills will be better. Human studies have shown this, as well as animal studies. Physically active adults have lower risk for dementia. You don't have to become a triathlete. One study showed that just 30 minutes of brisk walking each day lowers Alzheimer's risk. Arthur Kramer, when he was at the University of Illinois, did this study where he took middle-aged and older volunteers, had one group walk briskly, the other group just did some stretching and toning, and he did MRI scans and found that the hippocampus, one of the key memory centers in the brain, grew in the walkers and atrophied in the stretching and toners after 6 months and after a year. What about mental exercise? I think the evidence here is not quite as compelling as it is with the physical exercise data, but still there's a lot of evidence. If you go to college, if you speak more than one language, you have a lower dementia risk. I showed you the study we did, Your Brain on Google, how it activates neurocircuitry. And then there's also specific mental exercises that actually teach people techniques to compensate for their age-related memory loss. And we did a lot of those studies at UCLA. There's been large-scale studies on it. The evidence is relatively compelling. We did a study where we asked the question, what happens if you train people simultaneously in physical exercise and mental exercise? Because, you know, it's just, you get in that zone, you're exercising, the endorphins are circulating in your brain, you feel good, are you more alert? And sure enough, when we did this study, we found that there were different effects. When we had older adults sit on a stationary bicycle and learn memory techniques versus when they did it sequentially at different times. And we generally teach people very simple methods like look, snap, connect. So look as a reminder to focus your attention. Biggest reason people don't remember is they're simply distracted, and that's where the devices come in to distract us. Snap is a reminder to create a mental snapshot. This leverages the brain's natural ability to remember visually, and connect is a way of linking those mental snapshots so they have meaning. If something is meaningful, it will become memorable. And you can use this for many common issues of forgetfulness people experience. So if you meet Harry, notice his hair. You meet Ms. Bangle, she's got bangs, and then she gives you her first name after she tells you that she's an attorney, and that helps you remember her first name, Sue. And that can become an emotional memory if you've ever been sued. We all know how emotional memories tend to stick more. So you can learn these techniques. They can be very effective, but you know they can also be stressful, not remembering things. And there's been a lot of work showing that managing stress makes a difference, and stress is not good for our brains, both in animal and human studies, and in MRI studies showing you how there's functional change in different areas of the brain, depending on if you meditate or if you do deep breathing exercises. You could really change your brain through some of these stress management techniques. Another very important area is nutrition. You know, you've heard you are what you eat. Well, your brain is affected by what you eat. And this is a huge area of conversation, but just very quickly, weight management is important. Portion control. We know that obesity increases, midlife obesity increases the risk for late life dementia. You want to try to emphasize omega-3 fats that reduce heightened inflammation in the brain. So fish and nuts rather than red meat. Antioxidant fruits and vegetables fight age-related oxidative stress. The average older adult does not consume the recommended 7 servings. And then trying to minimize processed foods and refined sugars, increase the risk for type 2 diabetes, which doubles the risk for dementia. Now, even if you're overweight or obese, losing weight can help. And it's interesting to me, there's this new weight loss drug where a lot of people are losing weight, and I'm hearing from patients that they're noticing that they're mentally sharper. And the earlier studies looking at bariatric surgery patients who undergo weight loss surgery has shown that systematically, that after 12 weeks following the surgery, that there's significant improvements in memory performance. And after 2 years, those benefits are maintained. So good news on the nutrition front, that there's been generally a correlation between modest alcohol consumption and better brain health. We're not sure why that is. It could be something in the alcohol that is antioxidant. Resveratrol is in red wine. They've tried to test that out with resveratrol capsules, but we're not sure whether they penetrate the blood-brain barrier. So if any of you are on resveratrol capsules, you might want to wash it down with a nice Bordeaux just to be on the safe side. But of course, you don't want to have too much, because that is not good for your brain. We all know about Wernicke's encephalopathy. Caffeine also, caffeinated beverages in moderation are associated with better brain health. There have been a lot of studies looking at these so-called modifiable risk factors for dementia. Some I've mentioned, as well as others like traumatic brain injury, um, hearing impairment, et cetera. And it has a significant impact. There's no question that it really accounts for a lot of cases of dementia. So we can affect people's lives. Now, when we try to get more systematic about, I mentioned inflammation as an issue, trying to reduce inflammation in the brain. There have been studies looking at hormone replacement therapy. I didn't talk about that too much, but estrogen replacement therapy. But there tends to be an issue of when things work and when they don't work. And we're finding that, so for example, reducing inflammation early in the course of brain aging seems to be helpful, but not so much later. So when they found this association between consuming drugs like ibuprofen or naproxen and a lower risk for dementia, that went right to clinical trials of ibuprofen in patients with dementia, and they found it didn't work. If anything, it may have made things worse. So I think there's a tipping point where there's a difference, because when we studied celecoxib or Celebrex, a COX-2 inhibitor anti-inflammatory drug, in people before they got dementia, people with MCI or normal aging, we found it did work and improved cognitive skills and actually improved brain efficiency in the frontal lobe using PET scans. So, and this is, I've been fascinated about this inflammation hypothesis, and there's still debate about plaques and tangles, whether they're cause or effect. And so, if you look at inflammation, it's a normal physiological process that protects our body. It's involved in the immune system, and all these anti-inflammatory strategies that seem to protect our brain health, like a good night's sleep, consuming omega-3 fats, or physical exercise. There's a theme there. So we tried to look at other ways to reduce inflammation besides anti-inflammatory drugs, because, as I mentioned, they can not only accelerate brain aging, but they have a lot of side effects. And we don't want to expose everybody to these drugs. So in our search, we came upon a spice, curcumin. It's a component of turmeric. And not only is it anti-inflammatory, but it reduces oxidative stress. In the laboratory, it's anti-amyloid and anti-tau. And so, and there were epidemiological studies supporting the use of spices like this. And when we did a study looking at it versus placebo in these same people with mild cognitive impairment or normal aging, there was a moderate effect size, a significant effect over 18 months. And we're working now to replicate that study. We're going to do a larger study here in New Jersey and collaborate with UCLA to confirm these findings. So what other lifestyle strategies are important? I mentioned head trauma. So wear a helmet, that's important. Stop smoking, stay positive, that's important. Those positive outlooks are contagious, and that's great. And simple measures that we take in healthcare to treat hypertension and high cholesterol will protect brain health. Now, in the area of head trauma, we've also studied that because the probe that we developed at UCLA measures tau. And, there's been a lot of concern about head trauma, particularly in athletes. So a number of years ago, we looked at retired NFL players with this plaque and tangle probe, FDDMP, and we found some interesting results. And here you see just a summary of it. And actually, following the football players, we looked at military personnel who had undergone blast injury. So if you look at these are just different. You have a transaxial, coronal, and sagittal section of the brain, and comparing a control subject versus an Alzheimer patient, a football player, and military personnel. And the more red and yellow the brain is, the more plaque and tangle. And you can see in the Alzheimer patient, in the temporal region, parietal region, you see some yellow and green. But look at the football player. You see that, those three, in the top image, you see the really three areas. One is the midbrain that's red. And the two other areas, that's the amygdala. And if you've been following, if you know about chronic traumatic encephalopathy, you know that these individuals, it's not only cognitive impairment, but they have emotional discontrol. They get suicidal, they're impulsive, it affects their personality. So it's really very different. And in the military personnel, we saw a similar pattern. It was not quite as striking. It may be that those blast injuries, had a different effect than the repeated concussions that football players get over and over again. So let's, in the next few minutes, let me try to quickly go through treatment. So we have symptomatic treatments for Alzheimer's disease, medicines like rivastigmine or Exelon or donepezil, and they don't change the slope of decline. There's been research looking at disease modifying treatments that really go after the disease itself to change the slope of decline. The symptomatic drugs, here's the indications, the cholinesterase inhibitors and memantine, you can use them together. They have side effects that we watch for. If a patient develops GI side effects, you might want to try rivastigmine patch, which avoids the GI tract. There's been a lot of research looking at disease modifying treatments. They've tended to focus on clearing amyloid from the brain, but it's had a checkered history. The first one that the FDA approved, aducanumab or Aduhelm, if you followed it in the news, the company decided to stop the trial because they did an interim analysis. It didn't seem to have an effect when they got more subjects, and they thought there was an effect, so they went to the FDA. The FDA panel decided against it, but the FDA still approved it. But CMS voted it down in terms of wide range coverage. So it's not really used much because the insurance companies won't pay for it. Now, more recently, we have lecanemab that the FDA approved. There was less controversy, but there's still controversy. If you look at the effect size of this anti-amyloid treatment, it's comparable to what you see from the older drug donepezil or Aricept. Yet it has a lot more side effects, can cause brain edema and other problems. So, and it costs a lot of money. It's like about $27,000 a year. So just to try to wrap up here, how can we help people to change? After being in the business of psychiatry for many years, I can tell you it's not easy, but I've emphasized lifestyle, how important it is, and we can use our technology to help them with that. We want to educate people. We want to find programs that are fun and easy, and we want to try to motivate people. So, what we do in our books or in our programs, that, by the way, when I was at UCLA, our longevity center devised these memory training classes, and you can search UCLA longevity center, and you can come to those classes, and they're licensed all over the country. But we try to motivate people. We give them little cognitive tests, and they see how they're improving, and that motivates them to go for the long haul, because you can't just be a weekend warrior with the physical exercise and the healthy diet. It really has to become long-term habits to make a difference. So let's see how well you did. You probably remember his name as Barry. That's correct. And then this, if you ever got sued, you remember Sue Bangle. That would come back quickly. Now it's not, it's not a perfect method. I mean, some people get it wrong. I remember meeting a guy named Waldorf, and I almost called him Mr. Astoria the second time I saw him, because I saw him standing in front of the iconic Waldorf Astoria. But just very quickly, just a practical case. You've got a 64-year-old man, has rapid and steady cognitive decline over the previous year, possible personality change, family history of bipolar disorder, as a first-degree relative with Alzheimer's disease, taking diazepam occasionally for insomnia. Now, that can be a red flag. People often don't admit how much they're taking their sleeping pills. He took donepezil, but stopped because of GI effects. His mini mental state is 20 out of 30. He's got this effusive personality. Screening lab tests were normal. And so, they ordered neuropsychological testing to see is this Alzheimer's or frontal temporal dementia. It also could be bipolar disorder. It could be a lot of different things. It's probably dementia, given the mini mental state exam, its degree of impairment. And the MRI scan showed periventricular capping, or that white matter disease that you see, as well as atrophy, which could be nonspecific, but it was the PET scan, the FDG PET scan, which really gave you the diagnosis of Alzheimer's disease. You see that dark area, that's the sensory motor strip, which is spared, and there's prominent hypometabolism in the parietal area, and even some frontal hypometabolism. That kind of helped drive the prescription of a cholinesterase inhibitor. So in summary, early diagnosis of cognitive decline provides opportunities of early intervention, coordinated care, better management. There are several healthy behaviors that are linked to delaying age-related cognitive decline. And I think, our new technology can certainly help us with this, but there's both positive and negative effects. So, if we think about the technology for older adults, we can help them stay independent longer. There are lots of technologies help them age in place, from monitoring and so forth, staying socially connected. But our older adults also suffer from the same difficulties with overuse of technology addiction, and also losing their face-to-face human contact skills. So thank you very much for your attention, and I'll welcome trying to entertain some of your questions.
Dr. Samal, that was beautiful. I could listen to you for many hours.
You're very
Thank
kind.
you so much. Yeah, great to see you and great to hear you. And thank you for sharing so much wisdom. People are beginning to put questions in the Q&A. If anything occurs to you that you want to know about, please put that in the Q&A bubbles, and we will get to those. I had a couple of questions just to get us going. You mentioned kind of in that case the diazepam use sporadically of the patient. What is the current thinking about the relationship with kind of benzodiazepines and dementia risk?
Well, it's complicated. I mean, there's always a lot of it is based on epidemiological evidence. We know that as their cognition declines and they experience mild cognitive impairment, in fact, sometimes years before they actually are diagnosed with dementia, they experience behavioral symptoms. They get depressed, they get anxiety. So one hypothesis is that people take these medicines to calm them down. Another is that those who are taking these medicines, it can accelerate cognitive decline. I would guess that it's probably both, because if you're on an anti-anxiety medicine, you may be less motivated to engage in social interaction. You may be more inward and less outward. So it can affect you in that way. And we all know that especially something like diazepam, which is a long-acting benzodiazepine, it builds up in the body. It's stored in fat tissue. And so people can just get cognitive impairment as a result, a side effect of the medication.
That's great. That's great. Let me turn to a question from Jeremy Ware, who asks early on in the talk, are there any cognitive remediation sorts of apps or programs that have been shown to be helpful in preventing some decline? Yeah, I love those apps. And, are they helpful at all? The games we
can.
Well,
as far as prevention, I don't know. I think those are studies that would take quite a bit of time. So that would be kind of a randomized prospective study. I mean, you do find that people who spend time playing games, doing mentally stimulating activities, that tends to lower future risk. So you'd hypothesize if you get the right app, it may help. Now, look, I like to play a lot of games. It probably got me into neuropsychiatry research because I like solving problems. Now I'm playing, and I have no licensing agreement with any of these companies. I like to play Wordle and with friends, and I go into phases. For a while, I was doing things before the pandemic. I'd actually get newspapers. Now I just do it all online. I used to play Ken and those and Sudoku. So it varies, and I find it fun. I'm not doing it to prevent Alzheimer's. I do it because I enjoy it, but maybe it is because I'm socializing with my friends. We're playing our games and we're posting it and having a few laughs as a result of it. Now, having said that, there have been, there's a lot of companies that have developed different apps. Some have a lot of marketing, and so you see them all over the place. My experience with patients and using some of these apps is if they're not designed well, the patients get bored. So I mentioned earlier about you want to train but not strain your brain. So I think that's a challenge with a lot of these apps, finding the game that is engaging at the right level. So it's a challenge. It hits that sweet spot. So you're actually activating those neurocircuits like what I showed in this study. I worked with I consulted with the company years ago called Dakim Brain Fitness, Dakim. And because I was consulting with the company, I wasn't involved in the study, but they funded a study at UCLA that Karen Miller was first author on. And so this was, they developed brain games that were really quite engaging. I mean, the guy who was CEO, who came from the entertainment industry. I mean, the challenge for me as a consultant was trying to help them to actually get octane into the gas, so that there really were some techniques that people were learning. And so in Karen Miller's study, she did find, and these were people that were in their 80s in assisted living, who played the game, I don't know, maybe, I can't remember the exact, maybe a half hour or 45 minutes a day over a couple of months. And they found significant benefits to their cognitive abilities. Now, that's not to say that it prevented Alzheimer's disease, but it improved their age-related forgetfulness. And it actually was even better if they played for 6 months. So I think that study does substantiate that you can improve your cognitive performance if you play the right game.
Great. There's a question here from Jerry Pavlon Bloom. Are professionals or studies looking into psychedelic interventions for dementia?
Well, that's another area of study that I've seen. I was just at the geriatric meeting in New Orleans, and I think there might have been one poster on something like that where people have used, they've looked at cannabis, probably more so than psychedelics, but there is, a lot of work going on psychedelic microdosing treatment research. In fact, at Hackensack Meridian, we're in the process of developing a center here, because there seems to be a there more so with PTSD or so-called intractable depression, not so much for dementia. I think it may have a place for some of the agitation that we're seeing and calming people down, and if you can find the right dose. I think, before I left UCLA, I started to get involved with their cannabis research initiative, because cannabis was recreational in California for many years, and I had so many patients who were just using it to help them with sleep or pain, and there was very little data to advise them, because there was, it was really the Wild West. There was poor regulatory control and so forth. I think the research there is still in its infancy, but I think with CBD and even THC and some of the components of cannabis, that there are components that can have health protective factors, even in mental health. And in animal studies, THC and CBD have shown some neuroprotective effects. But the key, these studies are hard to do. You've got to find the right dose, you've got to find the right patient, you got to get control. And it's hard to do right now because of the federal regulatory environment. Hopefully that'll change in the near future.
Great. So a question here, whether epilepsy can cause dementia.
Well, certainly you can have brain damage from intractable dementia. And so it's something that you should be concerned about. Usually, if patients are treated well, the seizures are controlled. So, whether having a history of convulsions or epilepsy, whether that is a risk factor for dementia, that I don't know.
Got it. So there's a question from an anonymous attendee here. Dr. Smalley, is there a way we can work with early intervention, or is it an ongoing process before we can determine if there's a diagnosis of dementia?
Yeah, I think there is a way of early intervention. I think I was doing that. I've been doing that throughout my career. I mean, it was even when I mentioned my kids in the research on technology. Well, our kids, I would go to their schools and give like a little guest lecture, eat broccoli, or I'd teach them the memory techniques so they learn the capitals of the US states. So, and I think, it's never too early or too late to try to help people with their lifestyle. We have a problem with childhood obesity and childhood diabetes causing problems. So, I would say any of your patients, particularly if, even the young patients, you can counsel them about technology, the pros and cons of it. But you start in middle age, people, when they reach 45 on average, they have a significant decline in their memory compared to when they're in their 20s. So you want to start those healthy lifestyle habits early on. And so what I do with patients is I will, do the routine medical approach, but also ask about their lifestyle. No matter how mild their cognitive complaints are, what are you doing for exercise? I educate them about the importance of it. You're getting out there, you're social, and what's your diet like and stuff. So I think getting people on those healthy habits is very important. I think this is another area where technology can help them. There's a lot of technology, exercise apps and diet apps that can be helpful with people. And actually another initiative we're trying to get started here at Hackensack Meridian is a digital mental health center where we can bring a lot of these apps and also, CBT and all these other kinds of evidence-based psychotherapies can now be applied through apps.
Yeah, great. Julie DeMarco asked, do you recommend turmeric or curcumin supplements for those at risk or in early stages?
Yeah. So, I do, generally I will, when it comes up, the question of supplements, I kind of have an open discussion with patients about it. What are the pros and cons? What's the level of evidence, and help them decide for themselves. Because we did have that positive study with curcumin, it wasn't a simple study to do. We raised money from some foundations. That was almost the easy part. The hard part was deciding which formulation to use. And so we were, thanks to David Heber, who was then the director of the UCLA Human Nutrition Center, we found a Japanese company that had a form of curcumin that was quite bioavailable. And so that's the one we studied. It's called theracurmin. And if you're interested in that study, you can just give your brain some exercise, go on Google, or it can be on any search engine, and search UCLA memory curcumin. And that will take you to the press release that we did on that study. And it'll actually link you to the study itself, and you can read about it. And then online you can find, now there are probably other forms of curcumin that are bioavailable. I just can't vouch for them. I just don't know. It's a tough area. And we talk about digital technology. There are companies that are building digital formularies. Which of these apps actually have been tested, and which ones really we don't know how safe they are and whether they really work. And I think that's still the same issue with supplements. A lot of them you pay money for and they're not absorbed, and they actually can be dangerous in terms of some of the ingredients. So that's one that I think is helpful.
There's a thank you. There are a couple of questions here about kind of biologic or medical causes of dementia. One here, asking, well, do statin drugs protect and or hurt brain health? They do seem to affect memory.
Yeah. Well, in general, statin drugs do protect brain health because you're avoiding future strokes. There's no question about that. Do they cause brain damage and hurt memory? I don't think so. But you do have some people who get memory side effects from statin drugs. So usually you discover that, you put the patient on a statin and they notice that there's a kind of a time course that suggests that. If you're not sure, you can always stop the statin drug and see if there's an improvement and try a different brand that might not be a problem.
Great. Yeah, that makes sense. And another question here, can multiple TIAs cause dementia and what treatment is recommended? You were talking about TIAs. Yeah.
So by definition, a TIA would be temporary. So whether it causes dementia or not, I don't know. Whether those temporary lapses in brain circulation cause permanent damage. Often people who have TIAs also have small strokes, and we know that that can contribute to cognitive losses.
Great. And there's a question about the relationship of Parkinson's and memory decline, and how do you talk to a patient about that?
Well, yeah, Parkinson's is a tough disease. And in passing, you might have noticed one of the slides showed that if you drink coffee, you have a lower risk for Parkinson's disease. About up to 40% of patients with Parkinson's will develop dementia. So it is an issue, and it's not just dementia, but also depression. So this is a tough disease. You have the motor symptoms and the mental symptoms as well. And I think it's just making people aware of it, trying to help them each step of the way. We often prescribe the anti-Alzheimer drugs or the symptomatic drugs for Alzheimer's in Parkinson's patients when they develop cognitive losses.
Mm-hmm. I think that does it for the questions that I see in the chat. Anything, Dr. Small, that you'd want to leave us with? Any wisdom to go?
Well, I think it's this is really a conversation not just for our patients, but for all of us. And I can tell you in my own life, it's been meaningful. I feel really grateful that I've been able to get involved in this area of research and practice, to help a lot of people with it, to try to innovate in this area. But it's also affected my life. My wife and I, we've written a dozen books, most of them in this area, but other topics as well. And I like to vet this stuff. So if I'm talking about Pilates, or I'm talking about this kind of exercise, balance training, I'll try it out myself to see how it works, to get a feel for how this stuff works. And when you've been at the game for so long, it's compelling. So in many ways, I feel I'm in better mental and physical shape than I was 20 years ago, because I'm trying to not just talk the talk, but walk the walk, and it's really enriched my life.
Fantastic, so inspirational. So if we were to meet for dinner and there's a menu in front of you, what are your go-to things that you would like to order?
Are you worried that I'm going to red meat shame you?
No. I want to know what the expert would order.
Well, look, I'm big for whoever said all things in moderation and moderation in all things. So I'm not a vegan. I'm not a vegetarian. I do try to de-emphasize red meat if I can, but like if I'm going to a famous steakhouse, I'm going to indulge a bit. I'm not going to consume 12 ounces of ribeye, but I'll have some of that and enjoy it. I think it's really it would be that dinner would be letting people enjoy what they enjoy. I don't like to lecture people. Being a psychiatrist, I never got away with playing psychiatrist socially. This is how you should do this or that, or so I think it would probably be a fun conversation about what we're eating. Perhaps maybe we talk about movies, or what's your favorite show that you're streaming right now?
Perfect. Well, it is so great to see you, and thank you, Dr. Small, so much for joining us today. Thank you, everybody, for tuning in. We, as a reminder, if you wish to receive continuing evaluation credits, just complete the evaluation survey that automatically pops up in the browser as this webinar ends. We've been having a great conversation, connected together, and now the time comes when we're all kind of sent back to our offices and our rooms without even really a chance to say goodbye. So this is that chance, and it's great to see you again. Dr. Small, thank you for being here, and thank you everyone for joining us, and hope to see you next week.
Thank you. It's a pleasure. Great to see everybody.